Alex Small. It's my pleasure to welcome you all to the Empire Urology in-service review tonight. We have Dr. Eddie Kabarriti joining us to talk about urethral stricture disease. Dr. Kabarriti and I overlapped for a few years there at Mount Sinai when we were both medical students. Then he went on to Penn for his residency. He's now part of the SUNY Downstate faculty and chief of urology at Coney Island Hospital, where he has a special interest in reconstructive urologic surgery. This is a huge topic on the in-service and the board exam every year. I just pulled out my old notes, looking back at some of the AUA guidelines. They're pretty clear on this. So if you can get these guidelines down, this is super high yield, easy points to score on your board exams. So I'll turn it over to Dr. Kabarriti to bring us through it. And thanks so much for joining us.
Yeah, thank you, Alex. All right, it's a pleasure to be here, everybody. Today I'll be talking about the urethral stricture disease. Specifically, this talk is more focused on for the in-service than just to go over urethral stricture disease. I'll highlight a lot of the guidelines, their statements, and some of the data behind the statements. All right, so just an outline of my talk. We'll start out by reviewing the urethral anatomy. We'll talk about what a urethral stricture disease is. We'll discuss the etiology of the strictures, diagnostic studies, and then we'll go on to discuss some treatment options as well as post-treatment follow-up. So throughout this talk, I've actually put in many questions, and these questions are meant to reinforce a lot of the points that I'm trying to make, and these are in-service questions that you may see on the there's SAS questions that you may see on your in-service. So starting with anatomy, the urethra we divided into two parts. There's the anterior urethra and the posterior urethra. So the posterior urethra is composed of the bladder neck, the prostatic urethra, as well as the membranous urethra. And that part of the urethra is actually lined with transitional epithelium. Now, this is very crucial, especially in patients who have, for example, a positive cytology, and there's nothing within the bladder. You may be asked as to what's the next step, and that would be biopsying the prostatic urethra, because it is the positive cytology could be coming from there. The anterior urethra is composed of the bulbar urethra, the pendulous or penile urethra, as well as the fossa navicularis. And the anterior urethra is lined more with a sort of stratified columnar epithelium that really changes to stratified squamous epithelium by the fossa navicularis. And then in terms of arterial supply, we have the common penile artery, which comes off the internal pudendal, and that breaks off into the dorsal artery, which goes all the way to the glands, with some circumflex arteries coming off of the dorsal artery for the corpus cavernosa, as well as the cavernosal arteries. And then on the ventral aspect, you have the bulbar as well as the urethral arteries. The corpus spongiosum really has dual blood supply, and that is you have the urethral artery on the ventral aspect, which runs ventrolaterally to the urethra and terminates in the glands in the glands of the penis. And you have the dorsal artery, which goes all the way through the glands, and that gives the retrograde blood supply through these arteries as they arborize the glands of the penis. So here's the first question. In a penile reconstruction after amputation, microsurgical reanastomosis of the dorsal artery and vein is most important in preventing. And those are the choices. All right, just giving you a few seconds, and the answer is skin loss. And the thing that is important to remember is that the penile skin has actually a completely separate blood supply from the rest of the corpora cavernosa, as well as the spongiosum. And this actually plays a crucial role when we're talking about fasciocutaneous flaps. So the penile skin does have a dual blood supply, which comes off of the superficial or the externopudendal artery. And these combine to give blood supply to the penile skin. And the reason it's important in microsurgical reconstruction is when you reattach the dorsal artery and nerve microscopically, then it allows for arborization from the dorsal artery to the glands, therefore preserving the to the skin from the glands, which allows preservation of the penile skin. Here's another question. During the penile plication for 50-degree ventral penile curvature with a palpable plaque, the dorsal vein is inadvertently transected. The next step is and for this one is you just ligate the deep dorsal vein and you continue with the plication given the nice venous drainage of the penis. So what is the definition of a urethral stricture? And this is a lot of terminology. So the urethral stricture by definition is really a narrowing of the anterior urethral lumen, which is caused by scarring of the corpus spongiosum. Now, remember that the anterior urethra is surrounded by corpus spongiosum, but not the posterior urethra. And as you can see on this image, the urethra is actually differs depending on the location with respect to being within the corpus spongiosum. So approximately, the urethra is eccentrically placed, and it's much closer to the dorsal side. And this is very crucial when we're talking about placement, for example, of an artificial urinary sphincter, because when you're mobilizing that urethra posterior, you want to make sure you don't inadvertently get into the urethra, in which case you would have to abort. More distally, the urethra is actually more centrally located in relation to the corpus spongiosum. Now, the corpora cavernosa are intimately fused, and these are separated only by septal fibers, and that's crucial when you get a priapism case. Oftentimes, you only have to irrigate on one side, and that's because they are fused, and whatever you do on one side can actually cross over to the other side. Now, a posterior urethra, and narrowing the posterior urethra is more appropriately termed as a distraction defect or a stenosis or a contracture than a stricture. And that depends on the etiology in terms of how you would term that defect. So the etiology of urethral stricture, right? Many of them are traumatic and often spiral trauma, which could cause a mid-bulbar stricture with this significant spongiofibrosis. They could be iatrogenic after a transurethral resection, whether it is a prostate or a bladder. These strictures tend to be located in the Fossa Navicularis. A traumatic Foley insertion, think of the patients, for example, who have had hematuria and they've had multiple Foley catheters going in, going out. These are the patients who often could potentially go on to develop a stricture. Patients with hypospadias repair are also at risk of developing strictures after their repair is done. Now, less commonly now that we see these iatrogenic, only because we have improved scopes, we have flexible cystoscopy, and also there's a very limited indications for pediatric cystoscopy in children. So we are seeing iatrogenic a little bit less, but you know, the transurethral resection, the traumatic Foley insertion still happen. It could also be inflammatory, such as with lichen sclerosis, or it could be even infectious secondary to untreated gonorrhea. And then, of course, it could be idiopathic. So, and there's a difference in terms of the etiology of urethral stricture depending on whether we're looking at developed countries versus developing countries. So in developed countries, you'll see idiopathic is the most common reason, and that accounts for about 41%, and iatrogenic is about 35%. Whereas in developing countries, the most common reason is usually trauma. Now, in the US, the estimated incidence is about 0.6%, and the most common location is usually the bulbar urethra. All right, so how do we make the diagnosis, and what are the important parts of the workup? So, as with everything else, we always start with the history and physical exam. So we want to get what are the patient's obstructive voiding symptoms, the AUA symptom score. We want to ask about, is there any urinary spraying, any dysuria? So 13% of the patients will present with urinary spraying, about 10% will come in with dysuria. Any other symptoms such as UTIs, prostatitis, epididymitis, we doing a PVR to check if the patient has retention. This could tell you about the acuity of their stricture, especially if the patient is not able to urinate and is retaining a lot. Erectile function is crucial in the history. And number one is sexual dysfunction is more common among patients with a history of hypospadias failure and lichen sclerosis, but the erectile function could guide you in terms of when you're doing your operative planning in terms of what kind of repair you're going to do. Urinary continence could be critical, especially in posterior urethroplasties, any prior treatments that could affect what you offer these patients. Have they had endoscopic treatments? How many have they had? Any associated injuries such as pelvic fracture in the past or any other pelvic injuries, and any prior embolizations, because as we discussed when we spoke about the anatomy, the arterial supply could be affected, and that could affect what you offer these patients. And then as per the UA guidelines, we would also obtain a UA to rule out an infection as well. So and the goal of the workup is really to determine three things, and that is, well, four things: location, length, depth, and the density of the stricture. You could get a Uroflow, which is optional. It is typically what would make you worry about potentially obstruction. You could use the cutoff of 12 milliliters per second, but this is not specific. This doesn't tell you if it is truly obstruction versus detrusor underactivity, but it could just guide you or make you think potentially or put the urethral stricture on the differential. Here's just a Uroflow demonstrating that flat line that you often get with the urethral stricture, where the patient, once the flow reaches that peak velocity, it is unable to go above that. And this is typical of what you would see with the urethral stricture. Now, we could do cystoscopy as well. The advantages of the cystoscopy is that it allows you to directly see the stricture. And this could be very helpful in case your other tests are equivocal. The problem with the cystoscopy is you could only see the distal caliber of the stricture, and you are unable to determine the length of the stricture, and you are unable to really evaluate the degree of spongiofibrosis that is there. So it does not really adequately evaluate the length of the stricture or the urethra proximal to the stricture, but it does give you an idea of where the stricture is located, at least where the distal part of the stricture is. So here's a study, and this one also again tells you, sorry, here's a question. 32-year-old male has a weak urinary stream and recurrent UTI. So again, a lot of the things that you would ask about in your stricture. Now, this guy has a known history of urethral stricture, and he's undergone 3 dilations in the past, again, prior interventions. You do a retrograde urethroplasty, and which is demonstrated here. The next step is so for this guy, taking a look at his retrograde urethrogram, right? We see the urethra, the anterior urethra, the very distal part of that is actually very well visualized. Clearly, he has some abnormality within the bulbar urethra. The problem is this is a retrograde urethrogram, and you are unable to tell exactly how the proximal aspect of this, because of it could be this narrow, there isn't much contrast going into the posterior urethra. So for a patient like this, what we would want to get is a VCUG to really evaluate the proximal extent of this urethral stricture. So a retrograde urethrogram and avoiding cystourethrogram, we often get these especially for anterior urethra, proximal bulbar urethral stricture. So the advantage of the retrograde urethrogram is when you combine with the VCUG is that you can see the entirety of the urethra. So the retrograde urethrogram allows you to evaluate the anterior urethra, whereas avoiding cystourethrogram allows you to evaluate the posterior urethra. There's the typical smooth contour that you could see with the retrograde urethrogram, as well as the conical departure of the bulbar urethra as it goes into the membranous urethra. And then you could see that smooth constriction of the membranous urethra. And that's why on the prior question, you needed to get a voiding cystourethrogram to really evaluate whether that constriction was due to the membranous urethra or whether it was there was a further stricture even more proximally. Now, some contracts may and should slightly fill the prostatic urethra. On the reason we do the voiding cystourethrogram is really so that we could evaluate the posterior urethra. And on that, you should be able to see the nice smooth opening of the bladder neck as well as the filling of the prostatic urethra. The retrograde urethrogram and the voiding cystourethrogram allow you to delineate the stricture length, location, and severity. Now, there are drawbacks to the RUG and VCUG, specifically as they are operator dependent. And I would recommend that if you're going to do these, manage these patients, that you do the RUG VCUG yourself. The other thing is they can underestimate a bulbar stricture length in terms of how long it is on the bulbar urethra. So how to do a RUG. Usually the patient is laying down obliquely in 45-degree angle. You want to make sure that, and that is to prevent overlap of the urethral segments. So you want to make sure that you have your penis nice and on full stretch so that you try to, so as not to underestimate the length of the stricture. The lower leg is usually bent, the top leg is straight, and the urethra should be perpendicular to your C-arm. So here's a retrograde urethrogram that is actually normal. As you can see, that's just the constriction of the membranous urethra that you could see. In contrast, here is a retrograde urethrogram where clearly there's a nice stricture that is easily evident. So what is the role of ultrasound? If you're going to do ultrasound, first thing you want to use a 7.5 megahertz transducer. It has a high sensitivity and specificity, but only in the anterior urethra. The problem is it has similar drawbacks of the retrograde urethrogram, which is that it's operator dependent. The advantages of the ultrasound is the fact that it could tell you a little bit more about the spongial fibrosis, whereas the RUG cannot. So here's an example where on the retrograde urethrogram, it looks like the stricture length is about 1 centimeter. But when you're looking on ultrasound, you could see that the degree of spongial fibrosis actually extends well beyond the urethral stricture or the narrowing of the lumen itself. So this allows you to potentially plan a little bit better for your repair. So let's go to treatment options. All right, what can we offer these patients? And the most important thing when talking about treatment options is really identify the setting. Are you getting called in the middle of a case or an ortho case where they tried to put a Foley catheter and they couldn't? Or is this patient in the emergency room and they're in extreme pain? Or is this a patient you're seeing in the outpatient setting and they come in, they say, and they're having some lower urinary tract symptoms? So if the patient has acute urinary retention or there's a need for catheterization, such as in the OR, et cetera, you could always consider suprapubic tube placement or urethral dilation or a direct visual internal urethrotomy if you're in the right setting. The other thing when talking about treatment options is really identifying the goals of care. And this has to be discussed because different patients will have different goals of care. An 85-year-old, for example, who has multiple medical comorbidities may not want to undergo a larger procedure such as a urethroplasty. And what they may consider as their success is anything where they could avoid a quote unquote large surgery and not having to have a catheter in all the time or not having to have a suprapubic tube all the time. So they have to go through a DVIU once every 6 months. To that patient, that may be considered a success. But to a younger patient or a different patient, they may want to go for cures, so for a urethroplasty. So that is a very important conversation to have with the patient. Now, historically, there was this concept of reconstructive bladder where we always started with the least invasive and you go on to the more invasive. That has fallen out of favor with urethral stricture. So in terms of endoscopic treatments, there is urethral dilation and direct visual internal urethrotomy. These have been tried, and there is some data to support these. For more definitive or more curative treatments, there's urethroplasty, and that comes in many different forms. You can do an excision and primary anastomosis. There's a non-transecting urethroplasty. You could either do graft using buccal, lingual, posterior auricular skin, rectal mucosa, bladder epithelium that you could use for your graft, or you could even do flaps where you're using penile skin flaps. And then this is an underrated option that can be offered for many patients, and that is perineal urethrostomy, and we'll get into that a little bit later. Now, before we talk about treatment, I want to introduce the idea of urethral grafts. And this is for patients who are catheter dependent or on CIC. And the idea behind this is that by putting the suprapubic tube and allowing the stricture to really declare itself. So we put the suprapubic tube, leave it for about 4 to 12 weeks. The stricture will declare itself in terms of how the severity as well as the length. This maximizes success really by just allowing the true extent of the stricture to be appreciated when you go in, and if you're going to do a urethroplasty or whatever treatment you choose for that patient. Now, a similar period of observation is also recommended before reassessing the stricture after failure in a patient who is already treated. So either a urethroplasty or dilation or even DVIU. So endoscopic treatments, let's talk about the success rates. And what, as I mentioned before, what is the definition of success? To some, the definition of success is not requiring any other surgeries ever again, or any procedures. To others is avoiding, it could be potentially avoiding a bigger surgery or not requiring a Foley catheter. So that is something that you will determine by discussing it with the patient in terms of what their goals of care are. DVIU and dilation have very, very similar outcomes. And depending on which study you look at, their success rates could go from anywhere from 20 to 74%. Now, the optimal candidate for an endoscopic treatment is somebody who's never had any intervention, somebody who has less than, their stricture is less than 2 centimeters, and you could even use 1.5 centimeters in length. There really is no, that stricture is without any dense or deep spongiofibrosis, and if it is located in the bulbar urethra. Now, of course, endoscopic treatment can maybe considered as a palliative measure for any patient who is not a candidate for urethroplasty, as I mentioned earlier. So dilation, the goal of the dilation is really just to stretch the scar without producing any further scar. Whereas with the DVIU, you're incising the scar down to healthy tissue. And the idea is let's separate the scarred epithelium so that the healing occurs by secondary intention. And at that point, what you're doing is you're creating a raise between the epithelialization and the wound contracture. So if the epithelialization happens completely before the wound contracture, then that is a success. If the wound contracture happens first and the lumen has already narrowed, then the DVIU really has failed. Now, what is the best location for DVIU? Many of us during training, we did our DVIUs at the 12 o'clock position. And it's a question of whether that is the best location. As I mentioned earlier, proximally, the urethra is eccentrically placed. So when you're doing it at the 12 o'clock, you don't have too much corpus spongiosum over there, and you could introduce extravasation into the intracranial place. And more distally, you are not that far off of the corpora cavernosa. And you could potentially be putting this patient at risk for erectile dysfunction. So that is something to keep in mind. Other things that have been looked at with endoscopic treatment is the injection at the time of incisions. There's been studies looking at steroids and mitomycin C. Here's one study looking at mitomycin C at the time of DVIU. As you can tell, this is a study with very small number of patients of approximately 20 in each arm. And the recurrence rate in patients with mitomycin who got mitomycin C was 10%, whereas in patients who did not, it was close to 50%. But I would say these studies are very, very small, and we would need slightly better studies to make it, routine care. The next question is, you do a DVIU, and how long do you leave the Foley catheter in, or you do a dilation? Typically, the Foley catheter needs to stay in up to 72 hours. Leaving the catheter in for longer, such as for 6 weeks, is not necessarily going to decrease the risk of recurrence of these strictures. There is a question about self-dilation and whether these patients should self-dilate after you open up their stricture. Now, these patients do have, anecdotally, do have a lower stricture recurrence rate, but the optimal protocol is undefined. And again, I would go back to what I said before about what is considered a success rate. If the patient is doing self-dilations, but is not requiring the Foley catheter, but that maintains their urethra wide open, is that considered a success? And that's up to the patient to define. Now, self-dilation may be offered to patients who are really not candidates for urethroplasty. If you're doing an endoscopic treatment, you could offer them self-dilation. With regards to endoscopic treatments, success rate worsens when you're doing multiple endoscopic treatments. So if it's failed that first time, keep that in mind. If it's a penile urethral stricture, again, less likely to be successful. If it's a long stricture, less likely, even less likely to be successful. When looking at cost effectiveness, urethroplasty is cost effective when the success rate of the first DVIU or dilation is less than 35%. So the urethroplasty, it's the gold standard for urethral strictures. Keep that in mind when taking the in-service and you're faced with these questions. It can be offered for all strictures, but it should be offered for instead of any patient who needs repeated endoscopic treatments for anti-urethral stricture. It should be offered for patients who have recurrent Meatal or Fossa Navicularis strictures. And it should be offered really for any, as the initial treatment modality for any patient with a long bulbar urethral stricture. It has a higher success rate when compared with endoscopic treatments. Now, as we discussed with urethroplasty, you could do an EPA, or you could do substitution urethroplasty. And those can be done with grafts, which is tissue excised and transferred from one area of the body to another. And that will depend, what that depends on is how good your blood supply is, where you're gonna put the graft. So a new blood supply develops, and usually that process is termed take, which requires about 96 hours. Now, the first 48 hours is what's called imbibition, and that's where the graft really survives by drinking the nutrients from the adjacent graft host bed, whereas the next 48 hours, it's an osculation, and that's really when the true microcirculation is reestablished in the graft. So if you're transferring your graft to an area that does not have good blood supply, you're not going to have the imbibition, and your graft may not survive to an osculation. So typically, nowadays we use oral mucosa as the first choice when using grafts for a urethroplasty. One should not perform a substitution urethroplasty with allograft, xenograft, or synthetic materials unless you're doing proper experimental protocols and you have the proper RV approvals. And you should never perform a single stage tubularized graft urethroplasty due to its a risk of failure. And one should also not use hair-bearing skin for substitution urethroplasty as well. More importantly, it should not use it as a flap. So flaps should be considered for cases in which the vascularity of the graft is really compromised, because remember, a graft is only as good as its bed. In very select cases, it can be used with buccal mucosa for circumferential urethral repair. If you are going to use a flap, usually you want to make sure you use non-adhesive skin, loose skin, as well as it has redundant tissue. And you want to make sure that the vasculature of the flap is also good. You know, does the patient have pretty significant smoking history? Do they have peripheral vascular disease? That could potentially dissuade you from using a flap. And the flap ideally should be easy to transfer. It goes without saying that patients with the lichen sclerosis, you should never use their skin for a flap for urethroplasty. And then there's the idea of a staged urethroplasty, and doing it. These are reserved for very, very complex patients such as those who had prior surgery, have hypospadias, or potentially in the Fossa Navicularis. They do have a decent revision rate. Just in the interest of time, I will go on to it. So my next few slides, I'm going to try to simplify it. So we went over all the different ways that we could manage these anterior urethral strictures. Now I'm going to break it down by location. And I'll start off with some questions for each location. So you have a 30-year-old man with a maximum urine flow rate of the 12 milliliters per second that we spoke about. This gentleman undergoes a meatotomy for meatal stenosis. So you open the urethra to the coronal margin, but the lumen is still very narrow at 12 French. The next step is what is this question getting at? What they're telling you really is that we don't have a good understanding of the extent of his urethral stricture. You're not going to keep opening, not knowing how far back you have to go. So the next thing you're going to want to do for this gentleman is do a retrograde urethrogram so that you have a better understanding exactly of how long is this gentleman's urethral stricture, so you could plan or do the right, more appropriate treatment, because it would be a difference if the rest of his entirety of his urethra is strictured versus if he has, say, another 5 millimeters of stricture. Here's another question. 24-year-old man has a split urinary stream with significant bother. Examination reveals a circumcised penis with that grayish white plaque surrounding the constricted urethral meatus. So they're telling you a lot, telling you this patient, think of like sclerosis. Retrograde urethrogram reveals 1.5 centimeter meatal stricture, and the rest of the urethra is unremarkable. So compared to our prior patient, here you do know what you're dealing with. A biopsy of the meatus confirms lichen sclerosis. The next step is, now one thing about biopsy that I should mention is one can biopsy a urethra if they think it's lichen sclerosis, but if you're ever faced with a question where you think there's urethral cancer, the answer is always biopsy that lesion if you suspect urethral cancer. So for this one, it's distal urethroplasty with a buccal mucosa, given how length it is. And so both of these questions we're talking about meatal or fossa navicularis strictures. So for these, you may initially treat with either dilation or meatotomy, except if the patient has had prior hypospadias repair, if they've had failed endoscopic manipulation or prior urethroplasty, or lichen sclerosis, as did some of the patients in the questions. One can do a meatotomy or an extended meatotomy, and these can be very successful with success rates up to 87%. Now, if there's a recurrent stricture, a urethroplasty should be offered. So this should simplify management of the meatal and fossa navicularis strictures. Now let's go a little more proximally. Here's a case where you have a 24-year-old man. This is kind of a bit of a trauma slash penile injury question. So 24-year-old man is shot with a high velocity handgun in the mid-penile shaft. CT scan of the abdomen pelvis reveals no other injuries. RUG shows contrast exavasation from a 2 centimeter segment of the mid-penile urethra. The next step is, again, keep in mind the velocity. This is a high velocity handgun. It's a gunshot wound. So, and the degree of extravasation. And for this one, suprapubic tube placement, because of the fact that you have a 2 centimeter segment as well as the high velocity. So you're not going to go and repair it without allowing the urethra to declare itself in terms of the severity of the injury, which can take some time. Here's another question. A 45-year-old man has bothersome LUTs and a newly discovered 2-centimeter proximal penile urethral stricture. The best initial treatment is? So 2 centimeters, that's right at the cutoff. But remember, this is a penile urethral stricture. So as we discussed, endoscopic treatments are not very successful in penile urethral strictures. So for this patient, you're going to do substitution urethroplasty with a buccal graft. So for penile urethra, a urethroplasty should be offered. Why? It's more likely that the stricture is related to hypospadias, lichen sclerosis, or iatrogenic etiologies. And the success rate of endoscopic treatments is much, much lower compared with the bulbar urethra. And the success rates for penile urethroplasty for properly selected patients actually appears to be pretty good, regardless of the tissue or technique used. All right. The next question deals actually with even a little more proximal. Let's go. We're going now to the bulbar urethra. So you have a 28-year-old man with who sustains a striatal injury with bulbar urethral disruption. Suprapubic tube is placed for 3 months. So the idea of urethral rest. You do a cystoscopy and urethrogram, which reveals a 1 centimeter bulbar urethral stricture, which is very, very narrow lumina for French. The next step is? So you're going to do an excision and primary anastomosis. Remember, this guy will probably have pretty significant spongiofibrosis. So that's why endoscopic treatment is probably not the ideal option for this gentleman. But his stricture is short enough where you could do an EPA for him. So for bulbar urethra, you could break it down. Is it less than 2 centimeters? Is it greater than 2 centimeters? Number one. And what degree of spongiofibrosis does this patient have? So if it's less than 2 centimeters, you may offer him endoscopic management or urethroplasty as initial treatment. But if it is greater than 2 centimeters, you should definitely offer him a urethroplasty. Now, often you'll be faced with the long multi-segment strictures, and these can be repaired either with one-stage or multi-stage techniques, as we discussed earlier. All right, here's a question. 70-year-old man with Parkinsonian tremors and a history of an MI has a 7 centimeter penile urethral stricture after TURP. The next step is? Okay, and what I'm trying to highlight here is the role of perineal urethrostomy. This is an older gentleman. He's got significant tremors. He's got pretty significant medical history. He's got a very long penile stricture. So perineal urethrostomy definitely has a role. It allows you to bypass the more distal anterior urethra. An ideal candidate is a panurethral stricture that really spares the proximal bulbar urethra. And it has a pretty high satisfaction rate. In fact, when you ask patients, would you undergo this type of operation again, 97% of them will say yes. And would you like to undergo second stage urethroplasty to restore your normal urinary function? Only 26% say yes, 73% actually said no. So it's not for every patient, but there are some select patients where doing a perineal urethrostomy is the best option, as in our question step. So we'll go now to posterior urethra, and we'll talk about bladder neck contractures as well as vesicourethral stenosis and pelvic fracture urethral injury. Some of these actually are from the trauma guidelines as well. So bladder neck contractures, usually these are patients who may have had, we break them down whether they've had endoscopic prostate treatments. So patient after a TURP, for example, you may perform a dilation of bladder neck incision for these patients. In a post-prostatectomy, radical prostatectomy, you may perform also dilation or vesicourethral incision or a transurethral resection. So depending on which studies you look at, there's anywhere from 50 to 80% success rate. Similar to urethral stricture, there's a role for mitomycin C, although the data on that is conflicting. And in a patient who's got recurrent stenoses or contractures despite dilations in the past, one should offer them an open reconstruction. So a 42-year-old man is unable to void following a straddle injury. Physical exam reveals blood at the meatus and a large perineal hematoma. Retrograde urethroplasty reveals a complete bulbar disruption with contrast extravasation. The next step is again, as we discussed, this is a patient who's got a complete bulbar disruption and pretty significant amount of extravasation. So the idea is we have to drain this patient. So a pelvic fracture urethral injury should be broken up can be broken up into either early or delayed. So in the early, this is when the patient kind of first comes in. It's very important to make sure that a rug is performed on all patients with blood at the meatus after a pelvic trauma. And one should establish prompt urine drainage, but avoid blind catheter placement. So if you have a partial urethral disruption, one can consider or may attempt a single attempt of a urethral catheter placement with a very well lubricated catheter, but it really should be limited to a single attempt rather than repetitive attempts. And a lot of times when we as urologists are cold, somebody may have tried already to put a catheter in, so keep that in mind. And if they have a urethral disruption, especially if it's complete, percutaneous or open SP tube placement is the gold standard. Now, oftentimes you may get some pushback from our orthopedic colleagues, especially if they're doing an open reduction internal fixation, but it can from a suprapubic tube can still be placed in those patients. Now, you could consider a primary realignment in a patient who's completely hemodynamically stable, but a prolonged attempt should not be performed. Just a very limited or short attempt. And for those patients where you do perform a primary realignment, that you should monitor them for delayed complications. So many of these patients will go on to develop either stricture, ED, or incontinence. In the delayed stage, if you are called for these patients, ideally the definitive treatment should be delayed until all major injuries have stabilized and the patient can be safely positioned for urethroplasty. The delayed urethroplasty ideally should be performed instead of delayed endoscopic procedures, given the high failure rate of delayed endoscopic procedures. And then for preoperative planning, again, you would want to use the retrograde urethrogram as in combination with the VCUG, or one can do a placement of a cystoscope through the suprapubic tube site as well as a retrograde to really evaluate the degree of stricture. So just to talk about complications, this is in urethroplasty, not posterior urethra, but actually just in urethroplasty. So 8 to 15% will have recurrence. Erectile dysfunction can occur in about 1%. Many patients will have post-void dribbling and should be counseled about that. There is a risk of fistula formation or a urethral diverticulum. Here's another question. A healthy 26-year-old man undergoes a urethroplasty with a buccal mucosa for a 5-centimeter bulbar urethral stricture. The most common form of sexual dysfunction he may experience post-operatively is. So if one was to have attempted an EPA for such a long stricture, which hopefully nobody does, and you're mobilizing the urethra, one could potentially cause a curvature. But given that this was a substitution urethroplasty, more commonly what you'll see is ejaculatory dysfunction in these patients. And often that could be attributed to the bulbar cavernosus muscle, which is involved in the rhythmic contractions during ejaculation. I should mention some side effects of buccal urethroplasty, given the number that we do nowadays. Perioral numbness happens in about 26% of patients after 6 months. Difficulty with mouth opening when you ask them to open their mouth widely, that almost is about 32% at 20 months. salivary dysfunction in these patients as well. In terms of follow-up for these patients, there's really no well-defined protocol. It varies by surgeon and by patient, and it should be tailored to the patient's risk factors as well as the procedure that was completed. And one can follow these patients similar to the way we do the workup with history and physical, looking at their symptoms, a uroflow, a retrograde urethrogram with a BCUG, as well as a cystoscopy. So 50-year-old man has a weak urinary stream. There's no history of any prior instrumentation, and a retrograde urethrogram is shown. So the next set of slides are actually mostly questions. So we'll just go through a few of them just to really hammer some points home. So for this patient, when you're looking at his retrograde urethrogram, clearly there is some contrast going into the posterior urethra that you could see, but this is a patient that has a multi-segment stricture. So clearly he's got one stricture right there and then another one. When you're repairing these, there's often spongiofibrosis of that part of the urethra that's in between. So from looking at this, one could anticipate that the stricture is probably going to be greater than 2 centimeters, and it's in the bulbar urethra. So for that patient, it's going to be a substitution urethroplasty. All right, here's another question. Spread of urinary extravasation secondary to urethral injury below the urogenital diaphragm when associated with the tear and Buccal fascia is limited by the following fascial layers. This is more of an anatomy question. And it's Colles and Scarpa's got to remember that, those are continuous with dartos, and they are continuous with the insertion of the fascia lata as well. 25-year-old undergoes an EPA for 2 centimeter bulbar urethral stricture. So that's sort of pushing the limits, but can be done. Post-operatively, the patient experiences normal erectile function, but he has difficulty with antegrade ejaculation. We touched on this question, so the answer for this one would be the bulbocavernosus muscle. All right, a 25-year-old man has inadequate erections since sustaining a pelvic fracture in a motor vehicle accident 2 years ago. After successful urethral stricture repair, he denies any difficulty with orgasm and ejaculation. You do an intracavernosal injection for his erectile dysfunction, and that produces a soft erection. The next step is, so in this gentleman, you're going to be worried about potentially what's going on with his penile artery. So for this patient, given the fact that he did not have the erection that you would expect with the prostaglandin, you're going to do a Doppler study of the penile arteries. 10-year-old boy with perineal butterfly hematoma following a straddle injury, another anatomy question. And again, just remember that if they do have the butterfly, that means there's been extravasation through the corpora and through the spongiosum. So what this suggests is rupture of the corpus spongiosum, and it's kept in that place by Colles fascia. And that is all.
Dr. Kabarriti, that was awesome. Thank you so much. That was a really, really great talk. Super high yield. The questions were perfect. Those literal questions, I think some of those were definitely on in-services past. I think on my boards, you'll always see at least one picture of a rug